Okay, this is a facet joint cyst. This is a rarer cause, so it's not always disc. We think disc, but sometimes there can be other causes of radicular pain.
I think you might as well go through this.
Okay, so so what we'll sometimes see is a mass on CT, but we can't work out, is it of disc density or is it of fluid density? So what's happening here is a ganglion, a bit of fluid is coming from the facet joint as a cyst, and that's what's causing the mass effect. And as said here, my technique for this is to actually put a needle into the facet joint. So in fact here, I'll show you. So here's degenerative change of the facet joint, and a ganglion is coming into the spinal canal and causing mass effect on the nerve. And here's an example where what I do is I put a needle into the facet joint and I try to aspirate out this ganglion, get the fluid out. Have to use a lot of pressure, and then we only put a very small low dose of steroid in to try to settle down the inflammation in this area, reduce the size of the ganglion, and then I will also inject it at another level, the nerve that's being compressed. So we give a sort of symptomatic relief to the nerve, but we also treat the ganglion as well. Here's a great case where there was a patient who had the facet joint cyst causing canal stenosis. We did the injection, and then the specialist wanted to repeat the MRI, see how the patient was going, and you can see that the cyst is completely resolved and there was no need for surgery. So that was a great outcome, and the patient was much better clinically.
I've mentioned before that the sacroiliac joint is a component of back pain in about 20% and it's underdiagnosed. There are lots of causes. Pregnancy, obviously, one. It's much more common in women who've had babies. Partly relaxing, additional weight, altered gait, large babies, difficult labours, etc. Biomechanics, leg length discrepancy. 75% of people who have fusions at L5S1 will have degenerative changes within their SIJ 5 years' time. And it's a bit like the knock-on syndrome going up. It's knock-down syndrome, obviously. There are other causes.
So diagnosis, X-ray, there's a grading system that was done in New York, which is used for the anti-TNF inhibitors, but we can also pick it up with the more complicated imaging showing changes that you can see here. Usually starts on the iliac side of the joint, but we can see on MRI here erosion, bone marrow edema, sclerosis, but the gold standard as far as getting a response is to do an actual sacroiliac joint injection with the pain chart, which I'll show you later.
And other treatments include physiotherapy, exercises, anti-inflammatory rest, SRJ belt, treating the underlying cause, etc.
So similar to a facet joint injection here, I'm putting the needle down into the sacroiliac joint and then injecting usually a larger volume into the sacroiliac joint under CT guidance.
Radiofrequency not as effective with sacroiliac joints as compared with facet joints because you have to get not only the posterior primary rami but also the anterior primary rami, and also there aren't really any effective trials. The surgical fusion is rare these days.
Okay, case 7. This is a case that you may all be seeing at the moment. So cricket season's on. You've got the 13-year-old talented junior. The parents have brought in their son, who they think is going to be the next superstar, and they're worried if he's doing basketball, and cricket, and football, doing all these different sports 7 times a week, and the patient's getting left-sided lower back pain, worse with extension. They've got what sort of diagnoses should you be considering in this age group? Anyone out there? Anyone? Yeah, stress fracture. So a pars stress fracture. Okay, so this is a sort of quite a specific diagnosis. This is quite a pet interest of myself, and we've done a lot of research at Victoria House, and we've worked with a lot of elite sportsmen with this condition. But yeah, pars stress fractures. So what we're talking about, the pars, it's the bridge, the sort of central point of the vertebra which transmits forces from anterior to posterior and is involved with rotation. You can see here on CT we've got this fracture passing up through the pars. Now traditionally we would do X-ray, but X-ray is a very late modality to pick this up, and usually there's an established chronic complete fracture and a complete defect. But what we want to do is try to pick these up early. We want to find the stress reaction or the acute incomplete fracture so that we can give the patient a period of prolonged rest so that the bone will heal over and then they won't get the slip, they won't get the chronic symptoms. So the best way of looking for that in this young population is using MRI. So we've done a lot of research and work on that. And what we're Sherman's disease, that's usually thoracolumbar. So thoracolumbar, it's usually not as much with doing so much activity and not usually get as much extension pain. But yeah, that's more changes in the disc in the end plate. This is more a true bony stress reaction. And what we're able to do with our 3T MRI is we have special sequences which are able to pick up the bone marrow edema. So this is white bone. We make all the other bone dark so we can see this marrow edema. And then we've got a special sequence called VIBE, which enables us to see the fracture. So previously we were doing CT scan, but now we're able to use the VIBE sequence to actually show the fracture and do just one test to make the diagnosis. We've done a research project comparing CT to MRI to this VIBE sequence, and we've shown excellent result with the VIBE, and it's currently been submitted. We're awaiting acceptance from the journal. But there are different sort of injuries that we can see. We can see an incomplete fracture, which you can see here. So passing up, this is on CT, but we can pick it on this VIBE sequence. The normal cortex, you can see on CT, is intact here and intact here in black. But as we come up, we can see this defect in the bone, the incomplete fracture. We can also have a complete pars stress fracture. So here's the fracture going the whole way through on CT. We can show that on this VIBE sequence, and then we can invert that. We can do special magic with our MRI. We can invert the VIBE image so that it looks like a CT scan. So the sports physicians, the physios are all very excited about this ability to make this diagnosis and to grade it, accurately grade it with one test. We can also show that this pathology can occur at different locations. So it can actually also occur at the pedicle-vertebral-body junction. So here's the bone marrow edema on the stir, here's the fracture on the VIBE, and the fracture on the inverted VIBE.
I'd just like to make a comment about the VIBE, the T1 VIBE. Not every radiological facility, even within MIA, actually does this. I actually had to speak to Andrew to pass the information on to one of the practices down in Frankston, who now do the inverted T1 views. And when you, so I would be specifically referring to Victoria House at this stage. I don't know whether that's going to happen, whether it's going to change down the track. And when you actually look on MIA Direct, you get the T1 VIBE view up and you put Shift I on the keyboard and you'll get the inverted VIBE, and it looks a bit like a CT scan. So it's really quite useful. You can actually see the fracture. So it's common at L5, very high incidence, much higher than we think. Goes up to about 15% in elite athletes, and about half the fast bowlers have stress fractures. Obviously, most commonly unilateral, and they heal reasonably well as opposed to the bilateral. Some individuals are genetically predisposed to this, so a trapezoid, which is slightly wider, L4 vertebra is more likely to cause pars defects. A thin pars, and Inuits, you know, the Arctic indigenous people, they when they're carried in a sort of baby pouch within inside a parka, they during infancy, they have about a 40% rate of stress fractures, more common in men as well. I think we'll move on. Management's pretty controversial. If you've got a unilateral pars defect, definitely worth resting them for a certain time. And despite the fact that if they get non-union, they often get a good result. Again, core stability is very important, particularly with pars defects, because they've lost their bony continuity. And the next. And with elite fast bowlers, this is, you know, in conjunction with Cricket Australia and with Victoria House. They have an MRI at the beginning of the season. If they've got bone marrow edema, they've got an increased risk of stress fractures throughout the season, so they are trained in a slightly different way. And they have an MRI for diagnosis, an MRI at 4 weeks, which usually looks worse. They protect the fracture for about 8 weeks and then have a further MRI. And if the healing looks as though it's starting to happen, then they'll start to do a strength program and reloading and commence gentle running. And they might transition to return to play at about 16 weeks and return to play at about 20 weeks. So you know, you can certainly get healing in unilateral past defects.
So here's an example of so we've done, as Tim said, we've done work with Cricket Australia, and here's an example of a fast bowler. So a diagnosis on the vibe, you can see this incomplete fracture passing up. Even though he's resting at this point, the osteoclasts, so the bone turnover are beating the osteoblasts, so the fracture actually increases in size. And then subsequently, we can see this increasing sclerosis at the pars fracture, and we can then see at 4 months this is healed. So this is exciting technology. No longer doing serial CT scans, we're doing serial MRIs, and we're able to give good prognostic information. If we move on now to the red flags cases, so these are important for you to consider. So this is an example, a 60-year-old, past history of breast cancer. She had initial lumpectomy and axillary dissection, but now she's got a new onset of lower back pain. And what's concerning to you is that there's night pain and there's non-mechanical pain. Okay, there's some of the things you need to click into gear, think about. We would still do an X-ray to give an overview as to what's happening. Can anyone see the abnormality on the X-ray? Okay, I'll help you out. So yeah, so we can see if we look at the level below, here are the normal pedicles on face, so we're looking through the pedicle, we're looking in here, but when we come over here to the left side of this vertebral body, you can see this expansile lesion inside the pedicle. So that's where, there's something going on in there. There's then different modalities that we can apply to this clinical circumstance. So it's important to understand the use of those modalities. So MRI in this setting is used to assess for canal stenosis cord compression. So does this patient need radiotherapy? Is there some sort of critical clinical catastrophe that's going to occur? And what we do is we look on the T1 weighted, so the CSF is dark, normal marrow is fatty as we age, and you can see here replacement of the marrow by this low signal lesion. And then on T2 weighted we can see the lesion as well, but we can see the relationship of the lesion to the cord, and there's CSF there. So this is not a critical scenario. We can see other cases where there'll be epidural tumour or where there'll be a pathological fracture which is compressing on the cord, and that's more clinically urgent. Okay, bone scan and CT, they're used for staging to give an overview. So bone scan, we want to see, is the lesion single or multiple? So unfortunately, also in this patient, they've got increased uptake here in a rib, so they've got another metastasis to the rib as well, not just the vertebral body. This is obviously the bladder where the tracer has been excreted. And then we use CT for soft tissue staging, so to assess lymph nodes, look in the lungs to see if there's a nodule, look in the liver, look for other lymphadenopathies. So MRIs to look to see if there's cord compression, bone scans for an overview of the bones, and CTs for sort of soft tissue staging. All the modalities can see the metastasis, but they're all used differently.